morning. Can you hear us okay in the back? We don't have amplification, but we do have our voice.
We'll talk loud.
Sounds good.
We'll try at least.
We'll try. If you can't hear, just let us know.
Yeah, just wait.
Okay. Well, we want to thank you all for joining us this morning. There's some technical things here that they taught me. Press forward. So my name is James Kwon. I'm the Deputy Director at the Office of the Public Guardian at the Department of Mental Health.
I'm Brian Hurley. I'm an addiction psychiatrist, and I'm the Medical Director of the Division of Substance Abuse Prevention and Control in the LA County Department of Public Health.
And I'm Connie Draxler. I'm the Senior Deputy Director for Reentry Services in the Department of Mental Health. And I have been leading the SB 43 implementation plan, and I have several of the key programs under reentry, including Public Guardian and some of our other key players in implementation. So welcome.
This is pretty sophisticated stuff.
They did not teach me this part.
Okay, I have an idea. What is that?
And then hit
You can go to view
Oh, view?
and then present.
Slideshow?
Yes, slideshow.
Slideshow?
Excellent. Thank you so much.
Yay. Just do your.
You may
do
be able
that.
to use this?
Yeah.
So the spacing is going to be creative, but we're going to make do.
Yeah.
So welcome again. Thank you for joining us today. So we're going to go through these slides, and some of them will have a lot of information on them, but we won't touch, you guys can read, so we won't touch on every single point. I believe that presentation should be provided after the fact. If not, we can definitely meet afterwards to get contacts if needed, because we have a very short hour and there's a lot of details that we want to go through. So, our goal is just to make sure that we can get most of your questions answered, but in that short hour, obviously, there will be some that may get left unanswered. And again, we want to have some direct contact with you if possible to discuss those points. So this is a training and a presentation on California Senate Bill 43, SB 43, and it's expanding the definitions and criteria for the term grave disability. So let's get into our slideshow, and I am seeing that you may not be able to read this. We swear we didn't turn it in this way. So maybe we do have to read them one by one. So this is a brief outline. There's 6 broad sections, and we're going to go over the overview of SB 43 and LPS. We're going to talk about the changes that SB 43 brought to grave disability. The details regarding grave disability criteria and definitions for involuntary holds, and then after that, how it may change conservatorship, and then we'll have some resources and some discussion. So hopefully,
Much better. A little better. Not
Okay.
great. A little better.
I actually have a solution to this. If you wanted to speak through the slides, I can actually try to fix this. Would that be okay?
Yeah,
All
let's do that.
Give me a second, but please
Yeah,
go.
we'll keep talking.
But go ahead and,
Yeah.
and continue with that presentation.
Yeah, the whole you can read part doesn't work if you read it. So, but luckily, the first couple of slides are a little bit easier to understand. So, LPS, many of you guys understand as Landrum and Petra Short Act, enacted way back, voted in 1967, enacted in 69. SB 43 was signed into law back in October 10th, 2023. And really, to me, it's the biggest change to the LPS Act since in its enactment back in the 60s. So for you, those of you guys who are not familiar, it's the law that governs involuntary holds and conservatorships, and really was an intent to give. Oh, so much better. Thank you.
Not
Not on the
Almost?
screen.
well on the screen. It's not. Maybe it's working its way through.
Okay.
Okay. Yeah. Now it
there we
is
go.
great. Yay! Good job.
And now you can read, so I can stop talking. But really, it was an intent to make sure that there's due process to psychiatric holds and long-term psychiatric holds. And SB 43, if you weren't aware, will be starting in LA County on January 1st, 2026. So that was a point that we've been kind of rehashing for the last 2 years because other counties have enacted SB 43 in some form or fashion within their counties, especially our adjacent ones. So the number one thing to note is that everything that we're talking about here will apply January 1st, 2026. So let's talk about what's changed. There's three major ways that SB 43 changes LPS implementation. So the first thing we talked about was the grave disability definition and term, right? Grave disability refers to an individual's inability to provide for their basic needs, basic personal needs due to a behavioral health condition, okay? So most of you guys are familiar with the term 5150. It's an involuntary hold. So it's where someone's put under a hold for up to 72 hours because they're a danger to either themselves, danger to others, or are, this term, gravely disabled. If a person is assessed as needing continued care, they may be held involuntarily under further holds, different types of holds. Okay. And so individuals with severe substance use disorder, co-occurring mental health and severe substance use disorders, and inability to manage personal safety and or necessary medical care was added to the gravely disabled definition. And again, that'll be starting January 1st, 2026. Moving on, the same term will be used to define grave disability, not just under these involuntary holds, but also a conservatorship. And so kind of understanding the terms, you can kind of look at these two segments, the current LA County definition, and then what will be the January 1st, 2026 definition of what grave disability is. So the previous definition, which is a person as a result of a mental health disorder is unable to provide for his or her basic needs for food, clothing, and shelter. And I think that's been ingrained into the practice of LPS for the past 60 years, right? Inability due to causative effect of the mental health diagnosis, the inability to provide for their basic needs of food, clothing, and shelter. So that structure still remains. What this new revised definition does is it adds a few terms into that, which is a condition which a person, as a result of their mental health disorder, a standalone severe substance use disorder, or a co-occurring disorder of mental health and severe substance use, is unable to provide for the basic needs of, again, food, clothing, and shelter, but also may not be able to provide for their basic needs of personal safety or necessary medical care. So we'll kind of break that down. And because the terms are so broad, there are definitions, but I'm sure that you guys will have questions about that. Moving on, this is this is slightly misapplied, the X's.
They are that column is fully filled with X's on the new definition, in case you're wondering where the original slide is.
This was meant to be
Should show like that.
this was meant to be an easy way to see what was new and what is not. And obviously that is not helping, but yeah, just assume the new definition is everything, right? So as you can see, the old definition did not include standalone severe substance use disorder as something that you can causatively point towards grave disability. And then there were not the two definitions of necessary medical care as a basic need and personal safety as a basic need as well. Again, just to go back, regardless of the new terms, there still is an emphasis on the causative effect of the diagnosis and the inability to provide for basic needs. And hopefully we'll get if the slide goes out, that should get fixed. Okay, so we're going to start transitioning into talking about what severe substance use disorder is. So this kind of aligns the law to the current clinical criteria from the DSM-5. I think one of the things that someone on the street or in a hospital, when they're being evaluated for grave disability, and as well as sometimes conservatorship, what needs to be considered is a lot of what someone is looking at when they're evaluating is current presentation. Obviously, if there's a law enforcement officer on the street and someone is in distress or needs help, they're not going to be able to say, well, they've had some substance use issues in the past 12 months, right? So a lot of what the definitions are going to be used for in terms of the severe substance use disorder would be, current presentation. And then, as it leads into further and further, the clinical needs and assessment needs within the hospital settings or during a conservatorship, there could be use of history to, garner more insight into that person's grave disability. However, a lot of the training that's focused, especially on the people who are being trained to write the holds, it will be based on current presentation. So I think a lot of you guys will have questions like, how will you really know, right? Looking at that, and some of that will be, up to that person writing the hold. But I don't think people are being trained to say on the street, let's think about the person's 6 months history. That's really not going to be realistic. And so we were going to segue to Dr. Hurley presenting on severe or substance use disorder and all the elements and kind of the cycle of care within that world.
Sure. So the DSM-5 definition of substance use disorder has 11 clinical criteria. Those 11 clinical criteria are written up here on the screen. You can generally think about them as loss of control. So some of those features are continuing to use even when it causes problems, using substances again and again, even when it puts somebody in danger, taking larger amounts than somebody intended. Like I went and intended to have 1 drink and now I'm 12 drinks in, and how did that happen? Or I was just going to use a little bit of methamphetamine, and here it is 3 days later after several episodes of use. Those would be examples of taking substances in larger amount than somebody meant to. And then consequences. Consequences might be, I'm no longer functioning in my job. I'm no longer functioning as a parent. I'm no longer participating in things that I should be participating in. Substance use is interfering with my participation in treatment is one example of giving up important activities, spending a lot of time getting substances, wanting to cut down, but not able to cut down, continuing to use despite physical, psychological problems, and not managing to do what you should do because of substance use. 2 to 3 of these is considered to be a mild use disorder. 4 to 5 is a moderate use disorder. 6 or more is considered severe. The statute, Senate Bill 43, extended grave disability for severe substance use disorder. So 6 or more of these. Now, we don't expect everyone who's designated to place 5150 holds to be doing a complete and thorough history, right? Like that is not the expectation. But it's not enough to sort of see somebody using substances in some context. And not everyone uses substances meets this criteria either. The key is food, clothing, shelter, personal safety, and necessary medical care. It's like the same functional impairments, slightly elaborated, right, around personal safety and necessary medical care, but it's significant functional impairments due to severe SUD or the combination of severe SUD and mental illness, right? So that's how that's how the context is shifted or will shift starting in January when SB 43 goes live here in Los Angeles County. But it's tied to the DSM criteria. So this is the DSM criteria, just to be clear. This criteria was written for clinicians to assess. Like that's who the DSM is written for, is frankly psychiatrists and other clinicians. So we're applying the DSM criteria without that past year designation. So the DSM says within the past year. For SB 43, it's at the time of presentation, right? Are 6 or more of these likely met given what I know? And then when somebody's placed on a hold, there's subsequent assessments and there's more diagnostic clarification. I'll say, having worked in psych ERs or other places, oftentimes I know the grave disability part before I know the etiology part. Just to be very clear, that's the most common thing is this person clearly isn't able to attend to their food, clothing, shelter, and starting in January, personal safety or necessary medical care. I may not know why, right? Is it a chronic psychotic disorder? Is it chronic methamphetamine use? Is this alcohol? You know, that comes later. Oftentimes the etiology comes later. Thank you. So, what we don't do is look at just one, this person is using methamphetamine. Clearly, we have to go take them to a psychiatric emergency room on a 5150. It's not just one example. It's the constellation, right? So like if somebody is using substances and appears intoxicated, let's say that they're slurring their speech. Let's say that they are, behaving in a way that doesn't sort of match, it's not appropriate to where they are. Simple intoxication is not the same as a severe substance use disorder, right? So a couple examples that we think could apply are things like multiple contexts of incapacitating intoxication. Not, I saw somebody intoxicated at one point. There's now clearly a pattern of this person persistently unable to attend to their fundamental needs because of repeated intoxication. Repeated refusing to use food, clothing, shelter, even when those things are offered because of substance use. Unable to care for personal hygiene, cleanliness, again, due to substance use, or repeated medical life-threatening substance use episodes. So what does that mean? If somebody, let's say in a hypothetical example, uses fentanyl and overdoses, happens all the time here now, although it's happening less and less with the distribution of naloxone and more expansion of service. But if somebody uses fentanyl and overdoses, that in and of itself does not mean that person has a severe OCD. There might be other, like that could be the person's first time using it. They'll never do it again. Like not everyone goes directly onto a psychiatric hold. But if the person has a repeated history of overdosing again and again and again, and they just can't seem to keep breathing, well, hey, sounds to me like the substance use is now causing this person to not be able to, survive in the world without repeated medical interventions. Maybe at that point they do. But it's the pattern, it's the constellation, not the individual instance. So again, the direction we're providing in our trainings is we need to consider the person's entire situation. So within this context, the CMS and the state and then the county has a bifurcated behavioral system. There's a specialty mental health system supported by MHSA, now BHSA, and mental health funding, and drug Medi-Cal system, which is largely a separate system, although there is some overlap of co-contracted programs, but it's a separate system of care that has its own set of licensing and regulation and funding. And that bifurcation happens nationally at the CMS level, travels down to the state, travels down to the county. So just to be clear, we do have two county departments, Department of Mental Health and the Department of Public Health, SAPC, that are managing separate billing systems and licensing systems. And that's how things are right now. So this is the substance use disorder system. That's the system that is supported and regulated as a specialty SUD system. And it includes a whole range of publicly funded, generally Medi-Cal funded services that include early intervention, right? So even before somebody has a diagnosable condition, we can use Medi-Cal funding to be able to pay for engagement and support and help people avoid developing a substance use disorder. We have outpatient treatment that is, people are living where they're living and they go and engage with the treatment program. That engagement can be in person, that can be through telehealth, it can be through telephone. There's a lot of flexibility in how somebody can engage outpatient treatment. There's intensive outpatient, that is 9 or more hours a week of outpatient treatment. So it's almost like going to classes. You know what I mean? You have like a curriculum that you attend and here you get. And then there's residential. And the reason I'm describing it this way is almost everyone I talk to that may not necessarily know that much about the specialty SUD system thinks treatment is residential. If you go to treatment, it means going to a physical place where you are contained and getting treatment on site. That is a level of care. And it's a vitally important level of care. I'm glad we have residential. It is not the only level of care. Not everyone with a substance use condition has to go to residential, right? Some people can benefit without needing to uproot wherever they're living, wherever they're staying, and they can still benefit from the counseling and the support and the medication services offered in SUD treatment. And yes, we have residential. And we have withdrawal management. If you've ever heard the word detox, detox is withdrawal management. It's medical management of withdrawal symptoms. We also have opioid treatment programs. These are special outpatient programs that offer methadone, buprenorphine, and naltrexone. Those are the 3 medications FDA approved for opioid use disorder, and they're specific to treatment of opioid use disorder, OTPs. Other levels of care can also prescribe naltrexone or buprenorphine, but only methadone can be dispensed from an OTP. That's like the one molecule that is sort of gatekeep behind an OTP. And then outside of what Medi-Cal covers, we have something called recovery housing. Recovery housing is essentially sober living. This is abstinent living spaces where people can go while they're in outpatient treatment. So if you have somebody experiencing homelessness, residential is a place they can go. They can also be admitted to recovery housing while they're in non-residential treatment, right? That is an additional option of a place to stay while you're getting treatment, right? So this is how the SUD continuum is built. Can you forward to the next slide real quick? Okay. So the service standards, that is the levels of care within LA County's specialty SUD system, happens at different intensity. So there's 5 major intensities. There's 5, you'll notice that there is 5 separate hexagons, I think it's 6 is the name of the shape that's up there. But at the most intensive, there's hospital care. We have 3 hospitals contracted with SAPC. They are, 2 of them are chemical dependency recovery hospitals. One is an acute psychiatric hospital. It's not an LPS facility, but it is a psychiatric hospital that admits people and bills us for hospital care. The hospital care is usually time limited, up to 2 weeks, which is actually relatively long as hospitalizations go. But it's focused on medical stabilization and withdrawal management, right? Short-term hospitalizations where people generally then go to residential treatment. Residential treatment is non-hospital care, right? So it's not a medical hospital, but it's essentially where people go to be able to receive treatment on the site. People stay on site. They have like a dorm or a bed, or where they sleep, where they eat, where they go to treatment. It's all in a contained place. Then there's intensive outpatient, 100 more hours a week of outpatient treatment, regular outpatient, 8 or fewer hours of outpatient treatment, and then the prevention early intervention. And this is part of a national standard called the ASAM, or the American Society of Addiction Medicine criteria. Before we go to the next slide, what is the right duration of a residential treatment? Does anyone know? What's the right amount of time somebody should be in a residential program? 28 days. So the correct answer is not a day longer than necessary. And for some people, 10 days, 2 weeks, they're reconstituted, they're motivated, they're engaging treatment, they can go ahead and participate in outpatient treatment outside of the containment of residential. Because truthfully, we support people recovering at the least intensive, the least restrictive level of care possible. When you're in residential, you're in residential. You're not necessarily routinely going about and doing other things, right? Because you need the containment of residential. So not a day longer than necessary. For some people, 3 months of residential is just the beginning. They need more. It really depends on the person. So there's a framework for matching what's going on with somebody, what's going on with their substance use, their medical conditions, their psychiatric conditions, their motivation to change, their recovery environment, like what's going on in their lives, and the right level of care. So I mentioned the ASAM criteria, which defines the levels of care, but there's also an assessment component. So the assessment component has 6 dimensions, and it's what's the chance that they're going to go use again? What's the need for withdrawal management? What are their medical conditions? What are their emotional, behavioral, or cognitive conditions? How ready are they to make changes? What's their relapse, continued use, or continued problem potential? And what is their recovery? So the idea is we do this assessment that then says, okay, this is the level of care that this person is appropriate for. And we continue to do a reassessment. I mean, you don't continue to ask every single question in the ASAM criteria. Like people's like early childhood generally hasn't changed over the course of treatment, but you do reassess, okay, how has the person's relapse risk changed now? I'll give you an example. The people I worry the most about are the people that say, Doc, I don't want any more counseling. I don't want any more meds. I'm good. I've been here for 28 days and I'm done. I'm finished. I've completed treatment and I'm just not going to use it. I'm like, what's your plan? I'm just going to cleanse for this and I'm just not going to use it. I'm terrified. It's the people that say, Doc, I'm really worried. I recognize that the triggers for relapse are people, places, and things. And I figured out some of that. I know how to stay away from certain people, but there's some places that I can't avoid. I'm concerned. I'm like, great, that's an appropriate concern. Because the truth is, the duration of residential is much less important than the duration somebody's in treatment overall. Than somebody's in treatment overall. So if ever you hear a treatment program saying, we're a 28-day residential program, well, how many days of treatment do you think someone's going to get? Somewhere around, unless they leave, right, which happens. But if somebody chooses to stay for the full, you're going to get somewhere around 28 days. You'll hear people say we're a 90-day treatment. When you hear those things, recognize you're listening to programs put forward program-centered care. Program-centered care is you get what we give. And the ASAM criteria, which has been in place since 2017, has taken a lot of shifting of the way we do substance treatment. Is person-centered care. The whole idea is we develop a plan of care around the details of somebody's life. So there is no fixed duration of residential care. Medi-Cal will pay for residential care as long as it's medically necessary, according to the ASAM criteria. We will pay for outpatient care as long as it's medically necessary. For the ASAM criteria, there is no fixed limit because substance use conditions are chronic conditions. That is to say, people remain at risk. And what we do is we increase the supportive services available to people so that people can exercise recovery on their time frame and on their terms, right? So that's how the substance use system is built. And I make this point because even after SB 43 goes live, even though we have hospitals here, and SAPC contracted network care, none of the ASAM criteria levels of care are locked. None of them are locked. Our substance use system remains an unlocked voluntary system of care. Voluntary does not necessarily mean, how do I say this politely, entirely uncoerced. A lot of people go into treatment because of court, right? Because they would rather be in treatment in court than incarcerated. A lot of people go into treatment so that they can maintain the parental right, right? They may not want to go to treatment, but they would rather be a parent and have custody or parental rights than they are not. So they'll do treat. So just to be clear, I'm not saying that like it's completely people out of the blue. We sort of like there are coercive elements that, heck, save my marriage if I go to treatment, right? A lot of people go into treatment. Like there's all kinds of reasons why people choose to go into treatment. But the key is what we don't have is a locked setting where people are placed in treatment. And one of the reasons that we don't have those settings is there's not a lot of evidence those settings work. There's not a lot of evidence when you lock somebody up in a substance use treatment program that it supports their recovery. Oftentimes, and this is actually true with every lock psyche I've worked on, those are places oftentimes that are inflection points for people. But you're still left with engaging people with their ideas and their values and intentions and building appropriate supports that people will engage voluntarily. That's the fundamental thing that we use in serious mental illness, which is, most people, even when they're placed on a hold, end up in involuntary settings. That's the natural trajectory. The substance use system is one of those voluntary settings. So if somebody ends up in an LPS, which is a locked psychiatric facility, due to severe SUD, when the intoxication wanes, oftentimes the driver of that functional impairment will also change. You know what I mean? Like when when you're off of meth, when you're off of alcohol, when you're off of whatever drove you there in the first place, oftentimes your ability to get food, clothing, shelter, attend to your personal safety and necessary medical care will come back. You will get that function back. And so we don't want to miss opportunities to make sure for people for whom one of these levels of care is appropriate, right? Withdrawal management care, residential care, time-sensitive outpatient care is available and accessible to people with a severe substance use disorder, kind of where people have kind of just started their recovery. So that's our system. With that, This is another set of slides covering the same point that I made earlier, which is the placement in the substance use system is based on intake and assessment. What is going on with somebody? What are the things that we want to offer? What are the medications and the counseling and the support? Which is not frankly all that different from what we do in mental health care, which is medications and counseling and supportive services. You know what I mean? Like the system is different, but the domains are largely the same. The specific meds might be different. The exact evidence-based counseling practices might be different, but the core domains are similar. And then what is the level of care? Just a couple things about the ASAM criteria. One of the reasons the state of California chose it is because it actually improves people's engagement in care long term. If you keep somebody in residential for too long, they get bored and they don't want to do any more treatment, right? If you put somebody in residential treatment not long enough, they just go out and use as soon as they leave, right? So the idea is we want to reduce dropouts and help improve people's ongoing recovery. ASAM criteria does that. Here is what public funded SUD treatment looks like. I kind of already covered this in the more circular graphic to go through early intervention, outpatient, IOP, residential, outpatient, withdrawal management or detox. And recovery services include housing services. Recovery services also include, I'll just call it low threshold check-ins, right? Somebody provides a urine, a few times a month just to sort of keep track of their progress. They have a counselor that they talk to, see how their participation in community self-help programs is going. Right? There's a lot of ways that you can use long-term recovery service. And that's all part of what is in the SAPC network. Yeah. Onto grave disability criteria. Do I turn it over to you now, Connie?
It's going to go to James, but before we do that, I just want to comment that we've spent a lot of time talking about SUD only, right? Because that's a really new piece. And just remember that while we now see language about co-occurring, that's actually in the statute around grave disability, that's always kind of been there. It just wasn't in the statute, right? So for many people who have been detained and involuntarily placed in a hospital and or conserved, many of those individuals have a presentation of co-occurring. So that's not really new to the system, in my opinion. What is really new is this idea around SUD only, severe substance use disorder, and it being added to the criteria and to the definition.
Thank you for letting me belabor the point.
And I think just to add to that, again, people with co-occurring conditions, you may have treated one part of that with one spectrum of care,
right,
but the other still may remain. So it's not, like a one-shot cures all for both types of issues. And even within each spectrum, there's, other details that may need to get worked out in terms of a person's treatment plan. So, we talked very extensively about one of the new criteria and definitions, which is, again, severe substance use disorder. The two other additions are additions to the definition of the basic needs portion of the grave disability. Again, food, clothing, and shelter are currently in place and have always been in place. So an inability to provide for your food, clothing, and shelter as a result of any of those conditions could have meant that a person is gravely disabled. Now we add personal safety and necessary medical care. So going into personal safety, that's a lot. It's a very broad term, but personal safety is all about a person's ability to live safely in the community. And grave disability based on personal safety consideration is, again, the ability or inability to survive safely in the community without that involuntary detention, right? 5150, successive holds, or even a conservatorship, right? And again, positive effect due to either the mental health disorder co-occurring or a standalone severe substance use disorder. And again, when we talk about that causative effect, that may not be so evident in the initial stages. And as Dr. Hurley mentioned, you can see the inability to provide for the basic need first before you actually link it to the specific causative diagnosis, right? So when you're considering there's someone's safety at risk, there's some observable warning signs here that you can see: impaired judgment, risky situation, I think here in LA County also may be a little bit different in how we see that than in a very small, quiet, idyllic coastal town, let's say, right? We see many people, maybe even including ourselves, that I frequently jaywalk. I don't know if that's a illegal.
Very, very brave of you. Yeah.
I live in the city of LA. I walk my dog in the city of LA. I go jogging. So I think there's a lot of context to the severe impaired judgment that leads to unsafe conditions for a person, right? But again, resulting in risky situations, right? Someone who's at risk for being victimized, unable to, due to their diagnosis, defend themselves from victimizations, unaware that they're being victimized. Those are some of the conditions. Something we see very frequently on the streets is inability to care for personal hygiene or cleanliness. And it leads to severe issues, right? Infection, other things where the person's condition is severely deteriorating. And then, of course, another thing that we see from time to time, their living condition, whether it's on the street, whether it's in their own apartment, wherever it may be, just so uninhabitable due to that particular diagnosis. And it's so significant where it just contributes to almost an immediately unsafe living environment. So again, we see a lot of people, again, including myself, where it could be poor hygiene or other things that are noticeable conditions. But again, you need to link it to that particular causative effect of that diagnosis. Otherwise, those can be just personal choices, right?
And if I can, James, just add on to that, we already have this element in a 5150. It's just called danger to self or danger to others.
Yeah.
So it's there in a 5150 already. Many of these things that we're talking about, what we've seen is some of those things that have been assessed in a 5150 and someone being involuntarily detained for danger to self. Well, now you could also qualify that under the new definition of grave disability. So they've just kind of really expanded that, taking some of those elements and moving it over into the grave disability section of a 5150, and then ongoing into the further involuntary holds or conservatorships.
And I think that's a really good point in that, not to get into really, really into the details, but for someone to move on to the successive longer holds due to their condition, there is a cutoff point where that danger to self and danger to others broad view has to be narrowed down more specifically to the term gravely disabled, including a conservatorship. Danger to self, danger to others wouldn't qualify. You need to be gravely disabled if you are to qualify for a conservatorship. So that's kind of where that would get fine-tuned during that treatment period to see exactly what are some of the issues that are at hand. So that was kind of personal safety in a nutshell. And again, I'm sure many of you guys have situations in your minds that is that personal safety, and every situation is unique. So that's just a very, very brief glance at it. When it comes to necessary medical care, it's a little bit more structured. But again, when you're looking at the definition for necessary medical care, we're talking about medical care that a licensed healthcare professional, who's working within their scope of practice, right? They determine that it's necessary to prevent that person's conditions from deteriorating, particularly when those untreated conditions, unknowingly untreated conditions and symptoms can result in serious bodily injury, right? So the mental health professionals, they'll be encouraged to make decisions that use their clinical expertise at that moment. And then again, further triage might be needed if someone's put on a hold, and they'll go into more detail. But some of these are the, very broad examples of someone who may be suffering from unmet necessary medical care, uncontrollable involvement bleeding, malnourishment, dehydration. I think we see that quite frequently. Seizures, convulsions. There is a specific code section in the health and safety code that refers to, kind of what is the bar for that medical care not being met that would cause concern to say that person is not able to provide for their own necessary medical care. And then moving on, there's a couple other changes that SB 43 created, which also includes, making sure that the conservator, whether during the investigation or during a reappointment, is looking at other options. I mean, that's both statutorily, but just in the practice of scope of most public guardians offices, that's already there because, you do not want to put someone on conservatorship who has a less restrictive alternate that they can go to. I'm sure everyone would want that. So, but they kind of cemented that in the statute to ensure, especially with assisted outpatient treatment and care court is covered in that investigation or reappointment. And I'm going to turn it over to Connie to talk a little bit more about that.
Yeah, so I want to just give, we'll spend just a few moments on this. I won't spend a lot of time because we do want to get to your questions, but how does SB 43 and Care Court kind of work together? This has been some of the major legislative changes that we've seen over the last couple of years. So, care is really about community-based behavioral health services and supports. And up until or currently based for individuals who have diagnoses of schizophrenia spectrum or other psychotic disorder. But I wanted to note that SB 27 was recently signed by the governor, which will expand the definition of who qualifies or who is eligible potentially for care court. And now that will include bipolar disorder with psychotic features. So it's like one element of your bipolar diagnosis that will now be potentially eligible for care court as we go forward into January. So a lot happening in January 2026 with a lot of mental health changes. For those of you that don't know about care court, it's a civil court process similar in some respects to conservatorship, which is a civil court process where certain people like family and other professionals can file a petition with the court to try to see if somebody can be placed on a voluntary care agreement or a care plan. So that's one of the unique and distinct features between like care and conservatorship. So in conservatorship, we've talked about this whole process you need to go through: involuntary detention in a designated facility, and a referral goes to the public guardian for potential conservatorship investigation. In care, there's the ability for family, for instance, to go directly to the court and file that petition to see if a care agreement or a care plan can be obtained through the process if the individual is eligible. Care plan and a care agreement, like what's the difference between those? A care agreement is really a process by which the individual, they call them a respondent in care court, where the respondent says, I want to participate in developing my care plan. And that becomes an agreement between the respondent, the treatment provider, and whoever their supporter is. So that's a care agreement. A care plan is we've gone through the process and not quite getting the engagement and agreement from the respondent. So the court says, you know what, I think this agreement is great. I'm going to order the care plan as a care plan, and respondent, I need you to comply. It's still voluntary, right? At the very basic level of care, this is a voluntary program that has court supervision. And so what you're hoping for with care, and what the intent with care was, that the black robe effect of a judge would really get an individual to participate in treatment without having to go to the more restrictive conservatorship, which is truly, you've lost the ability to agree to anything. Care still gives some empowerment to the respondent to participate in treatment. So I've given the eligibility here. I don't think I'm going to walk through all of them, but you can review this later. But it is 18 and over, specific diagnoses. You're going to see some things that look kind of similar to SB 43, ability to survive safely And just, some of those same kind of words are being used now consistently in a lot of the LPS Act. In the law itself, you're going to start to see very similar language. Why is that? Because again, as James said, one of the things that SB 43 says is look to something less restrictive, look to an alternative other than conservatorship. And so you're going to have some similar elements. If someone is having a diagnosis that meets criteria, not surviving safely, not participating in treatment, try care court first, or even AOT first before jumping to conservatorship. We're looking at a continuum of care, a progression up from least restrictive to most restrictive. Just a few things happening is that the Department of Healthcare Services at the state is actually working really closely with hospitals up and down the state, but now really working with some of our hospitals in LA County, encouraging hospitals to do a petition or refer for care court first rather than conservatorship. Mm-hmm. So even as people come in currently being detained or in the future under SB 43, really the state is saying, hey, hospitals, did you look at that? Even though you have somebody on a hold, on an involuntary hold, have you looked at, can you file a petition? Now, the care court states that a hospital can file a petition directly. Hospitals have a lot on their plate. Is it kind of reasonable that hospitals are going to go file some legal document in the court and follow through with that process, at least the initial process? No. What are we doing in LA County? We are allowing the hospitals to refer those cases to care court directly and will petition. Here's a couple of advantages by them referring to us rather than filing the petition. We can potentially go see that client. Our care team can go see that client while they're in the hospital on the involuntary hold. We have the opportunity, a perfect opportunity to make contact with somebody, to start that outreach and start that engagement. Those are our goals that we have with some of our hospitals. We have a few pilot programs going on with a few hospitals to try and see if we can work this out to try and get people into a care plan or care agreement before they would even get discharged or be well on their way in the care court program before they get discharged off that involuntary hold. The court can order public guardian. So kind of looking at this, again, for public guardian, one of the things that they have to do is in the event that they get an investigation or referral to investigate, or annually as they're reappointing or investigating for the reappointment on conservatorship, public guardian must address whether or not a person can transition away from conservatorship to AOT or care. Public guardian is now held responsible to investigate that, document that in their court reports, and the court can question the public guardian whether or not they've done their statutory job in trying to move people down to a less restrictive system. So in our court has and will continue to order the public guardian. They will look at a case and say, public guardian, refer this to care court. We want care to take a look at this case to see if this would be more appropriate for care and AOT, but definitely care, rather than establishing a conservatorship to begin with or maintaining a conservatorship year after year. We've given you some resources. So when you get the PowerPoint, the links are in there. I'm just going to highlight self-help, that last bullet. There is a link there. This is the link to the self-help clinics at the court. So if you are interested in filing a care petition, Norwalk is where the care petitions are heard, is at the Norwalk Courthouse. There is a self-help clinic there. Not only are there court staff that will help you fill out the petition, but so are the DMH care team is also there. But you don't have to go to Norwalk. You can go to any of the courthouses in the county that have a self-help clinic. They will connect you virtually to the self-help team down at Norwalk and walk you through all the things that you need to do. So you're not alone in this process if you want to file that petition. In the event that you don't want to be the one filing the petition, you can always refer to the care team, and you'll see the link on there too to get connected with our care team. I do want to point out, because this is a point of frustration for families, while the CARE Act allows you to file the petition, which is something you've never had the ability to do, you don't maintain as the petitioner in that process. So if the court accepts your petition and it meets a basic legal level of meeting legal criteria, the court will send that petition to the Department of Mental Health, and they will name the Department of Mental Health as the substitute petitioner. So you as the family member, you do get removed at that first hearing, and your family member, your loved one who's the respondent, would have to agree to your ongoing involvement in the care process moving forward. So I always want to make sure families are well aware, because sometimes you get surprised that you filed this petition and then you get removed at the first hearing. So I always want to make sure that people are well aware of what may happen if you file that petition. And resources, and I think we are probably at question. Yay. So good. We left at least 10 minutes in case there are some questions. Question. Raise your hand.
I got a basic one.
Yeah.
Is this legislation, what do you think of it? Like, are you like, yes, I'm so happy to have these tools, or no, I wish this was different? Like, is this what you would have built for the problems you're seeing?
So it's definitely adding to our toolkit. And so I always appreciate when we have more options for engagement. And I think these help us engage people. And I will say, we'll see how SB 43 works out. But let me say for Care Court, we have seen that to be the case. We have hundreds of individuals who have either been referred or petitioned that when we engaged, they have voluntarily enrolled, not just engaged, enrolled in treatment and are maintaining in treatment, right? That's good. If you can get people to enroll and participate in treatment at the lowest level without a court supervised process, I think that's a win. So it's a tool in our toolkit. And I think that, SB 43, it will be another tool in our toolkit. I think I will caution, because I think with Care Court is there was a lot of expectations that this was the silver bullet. And I think there's some similar expectations with SB 43. And I don't think there's a silver bullet, right? It's a tool in our toolkit. It will help us engage more people. There may be some individuals who have never been 5150 before or were 5150 and didn't get very far in that process, where maybe that will change. And that's one of the things we're really focusing on at the department. We are going to be placing hospital liaisons from the Department of Mental Health with our designated hospitals, so that we're connecting with those discharge planners. Like, wait, here's a whole bunch of history. Here's what we know about this individual. Let's come up with a plan while they're hospitalized that could lead to discharge. For those that need to remain, in the hospital and conserved, that is a piece of the continuum. We are not looking to not have that be part of our continuum. It is, but we have to also look at other alternatives and effective discharge planning, because, as you all know, there is a limited number of beds, acute hospital beds in the system. We have to prioritize those acute hospital beds for the individuals that are severe of the severe, right? At the real tail end that need long-term hospitalization and or conservatorship. And for those that we can reach and engage on a shorter term hospitalization and then get them effectively connected to treatment, that's really a focus for us that we've been working on during our implementation planning. But I don't know if Brian or James has anything.
I would just want to iterate. I think many folks that I talk to in Sacramento hope that the next bill is just the thing. You know what I mean? Like, okay, we'll do this extension of statute, and that's going to solve everything. And there is no single line of statute that solves everything. To pivot, there was a bill that just passed, AB 1037, that LA County actually sponsored, and we were pretty excited about. We had a historically rigid and under-resourced substance use system. What does that mean? Substance use programs are, by definition, non-medical, which means that you had to get a separate license if you wanted to provide medication services in licensed settings. That's crazy, right? Medications are a core part of substance use treatment along with counseling and support. There was another part of the sort of older statute, which is you can't talk with somebody about anything other than abstinence. And you can't admit somebody they've used drugs recently. Which is sort of like, oh yeah, if you need treatment for a condition, then make sure you treat the condition before you get the treatment for the condition. And so 1037 actually updated a lot of that statute. But the point is, it's actually going to take a fair amount of iterative approaches and a system approach. How are we seeing these different parts of the system working together, and how do we invest? I think a lot about the voluntary SUD system of care to be adaptable and responsive and have the capacity to take care of the full set of LA County residents, or who are Medi-Cal members, who are in need of care, right? So that's and that's not a just pass this law approach. That's a system approach that relies on some shifts in statute, but also requires a lot of intentional investments in the system of care we have here locally.
And I think if you look at medical care, which, sometimes isn't maybe getting the attention of things, I think, again, a lot of hope that was going to maybe allow certain people to qualify for a 5150 and potentially, right, thinking of some of our homeless population, active, medical issues that they're not addressing, whether that's visual with open sores or it's, diabetes that's unregulated. So you might see some additional ability to not just danger to self, danger to others, but now under this grave disability for people to qualify. But what changes in the hospital about somebody who's come in with significant medical issues? Does the hospital get to treat them involuntarily for their medical condition? No, that didn't change in the law. It's still the same thing now if someone's 5150 and they have unregulated diabetes and they end up in the hospital. There will be an assessment about whether or not that person understands their medical condition and whether or not they can consent. In LPS, involuntary medical treatment, usually requires some sort of two doctors saying it's an emergency or, a court order. So that didn't change, right? So we will still have that issue to deal with. It might mean somebody will be 5150 and they'll get into a hospital for potential assessment and or treatment, but there isn't like an automatic medical treatment, gonna happen. I see a hand back there. Yeah.
Oh, yes. I have a quick question. I was wondering if there's a safeguard against potentially family members gaining up on the individual by talking to their mental health providers or court officials, explaining their view of the symptoms, and doctors and court and other, like anybody involved with listening to them more than listening to the individual themselves. Is there a safeguard to prevent kind of like everyone gaining up with, or professionals gaining up with people gaining up against that?
So confidentiality,
especially
confidentiality and HIPAA regulations remain in both care and in SB 43. So a treatment professional can listen to a family member for history and information, but they cannot divulge any information back to that family unless the client signs a release of information. So nothing's really changed in that regard around the flow of information, protecting information, and because you're talking about both with care and with SB 43, if it gets into a court situation or even in a certification hearing officer situation, there are all of the boundaries associated with, this is a due process. All of these pieces of legislation still have due process in place, which is protecting the rights of the individual who may be subject to these new laws.
I have a quick question. Maybe it's a tangent, but for the hospitals, who determines what hospitals are included in that, in the circle, the scope of.
The designated hospitals?
And
Yeah.
also, just to kind of piggyback what you were saying, so a loved one, there's something called a REIS, right? Because I remember for my loved one, he was at a hospital and then he was transferred to another one because that hospital didn't have the resources for the one.
Yeah.
So he was taken miles away. And part of NAMI, we as family members, and San Diego Valley, that we have a sheet of the chronological illnesses, the hospitalizations, and everything needed, so that when something happens like that, we give the professional, this is a background.
Yeah.
But because without the medical professional knowing anything, you're at a loss.
Yeah, so in terms of hospitals that are going to be allowed to detain and or conserve, they are called designated hospitals. And so the Department of Mental Health is responsible for designating. A hospital has to file an application, go through training, be approved to be a designated hospital. That doesn't mean your loved one might not go to another hospital that isn't designated. So you could go, particularly EMS, if they see that there's a medical issue, they're going to go to the nearest emergency room there is. By law, they have to do that. If that happens to be an emergency room that doesn't have a psychiatric component to it or a unit, then your loved one, once stabilized, would then get transferred if they're still on a hold to an LPS designated facility. So that's kind of that process. And I think we're going to take one more question.
Yeah, I actually had three. We don't have time. But I'll just quickly say, the first was, will the care court definition be expanded now with substance abuse alone can be a reason?
No.
All right.
That was in fact.
The second is, I'm sure you're all working with NAMI for how do you extend the education? Like, this has been a great discussion today, but it's going to be very important to have like website, this, that, with public, information.
So we've been doing meetings at our SALTs over the last month. There's a couple more coming up. If you go onto the website, the LADMH website, and look at SB 43, there is the list of the upcoming regional trainings that are going on. But we will also, if anyone wants training, you can just request it through the link there, and somebody will get back to you to schedule more training.
We have a number of community trainings. Instalta's service area
leadership team. Yes.
And NAMI can help advertise.
Yes,
Yeah.
absolutely.
Yes.
They're so good at that. And then the third question is, will you be tracking the changes? So what happens? Is the world getting better? Is this really helping things? Are people more stable? Are they less hospitalized?
So we have come up with our metrics and outcomes that we will be tracking. Some of that will be around the numbers. We already track the number of 5150s, but now looking at the reason for the 5150s as well as conservatorship. So there is a lot of data that the department must already submit as a result of a piece of legislation called SB 929. And so we're kind of taking those elements, making sure that covers everything we think we need to do, adding a few other metrics and outcomes that we want to take a look at. And so we will be tracking that. Probably going to take us a good year to have anything substantial on that, but we will be.
Clinical scholars like Ryan was one that could help.
So there actually was so as Ken mentioned, I was a Robert Johnson Foundation clinical scholar at UCLA. We did for those that speak quality improvement, PDSA, or Plan, Do, Study, Act, in advance of SB 43's implementation in Service Planning Area 2, where we did a small subset of admissions and looked at how can improved care coordination do things like rehospitalization, support people's transition to housing. The evaluation is still being developed. Happy to share it with anyone who's interested. But the early results were very few rehospitalizations within like a 30-day period, and improved linkage to housing, right? So we actually think that the changes that are coming can be executed well, but a lot of the execution and that care coordination is in the detail.
Yeah.
All right.
Thank you so much, everyone.
Thanks, everybody.